And now we're broadcasting live. So we have Instagram, we have Facebook, and we're doing this through our podcast platform. So whether you're joining me live or catching the recording later, thanks for joining. This is kind of a bonus end of the year episode of our iDryNeedle to the Point podcast. Today it's just me. I'm your host, Paul Killoren. I'm a physical therapist. I'm a founder and president of iDryNeedle. If you've joined us, I guess just in the last quarter of 2020, To the Point, our podcast kicked off with a bang. We had an incredible list, an incredible lineup of researchers, educators, really industry leaders and influencers in dry needling. And we'll be back in 2021. We'll call it season 2 of our To the Point podcast. But today it's just me, and we're just going to talk. This is a clinical short, so same idea, to the point, meaning I'm going to try and keep this to 15 minutes or less. And we're going to talk about nerves, very specifically peripheral nerves, and what happens if you contact a peripheral nerve when dry needling. First of all, we posted some research on Monday, just an ultrasonographer looking at the location of the tibial bundle, so the tibial nerve, the popliteal artery and vein, relative to the mass of medial and lateral gastroc. And it's that kind of research that really puts dry needling safety. And as we get into it, you'll see that maybe a peripheral nerve interaction isn't a stark, urgent, adverse event as far as if our needle interacts with a peripheral nerve, but it's obviously most commonly an unintended, uncomfortable experience for our patient. And honestly, teaching enough introductory level 1 courses, as soon as you start to talk about the sciatic nerve, the tibial nerve, just there's terror in your eyes about, I would never want that to happen. You know, what would happen? What will the patient feel? How long will it last? So I want to answer some of those questions today. So first of all, I threw up an Instagram poll on Monday, just asked how many of you out there needling have interacted with a peripheral nerve. Honestly, I expected 100%. We'll talk about that, but really as you get more distal in any extremity, the potential interaction with the terminal branch of a nerve is likely to some degree when you talk about very specific anatomy and techniques. So really the interaction with the peripheral nerve is common, but we'll talk about kind of how we can approach it, what we can do to mitigate the risk. So 93% of you said you've interacted with the peripheral nerve when needling. 7% of you either lied or have been so cautious with your needling that it's true. So to set the stage and to be very clear, we're talking unintentional contact with dry needling with a peripheral nerve. So first of all, unintentional means there are some very specific peripheral nerve stimulation techniques out there. They do use needles. Typically, they're interacting with the nerve using e-stim, so not a direct mechanical discharge or disruption or sensitization from a needle. But now we're talking, like for this, the context of this podcast, unintended interaction with the nerve without stim, just your needle close enough to interact with that nerve. And interact, we'll kind of talk about what that means. Is it just close enough that there's some pseudo paresthesia? Is it a strong enough contact you get an ectopic discharge, a motor response? We'll talk about all that. So unintentional, we're saying we're not intending to do it right now. I know there's going to be some of you out there saying, well, actually, if we interact with a nerve, that's not a bad thing. And I agree. If that's your intent, you do it appropriately, and you likely use stim, then I agree that that's not necessarily an adverse event. That's an intended target, intended goal. Secondly, we're saying peripheral nerve. So everything we're going to say about the anatomy, the technique, the safety for this podcast is specific to a peripheral nerve, not necessarily a dorsal root or a dorsal root ganglion. Those are much more noxious. They're much less anatomically protected as far as the presence and the thickness of an epineurium, and even their nutrition comes directly from the CSF, and their protection comes from the bony anatomy of the spine. So Unintended contact with a peripheral nerve. Just go through all of those in your head. Upper extremity, we're mainly talking the big three: median nerve, ulnar nerve, radial nerve. If you're proximal enough, you can talk about the muscocutaneous nerve or the axillary nerve. You can talk about the suprascapular nerve, the thoracodorsal nerve. Lower extremity, the big ones are the femoral nerve, the sciatic, tibial, common peroneal, distal in the foot being the plantar nerves. So again, peripheral nerve. And to start, I'll do the good, the bad, and the ugly of peripheral nerves with dry needling. And I'll start with the ugly. And that is that there are published case reports of dry needling causing nerve injury. Probably the most recent and the one that got the biggest press was in the BMJ, the British Medical Journal. Unfortunately, it did not give much detail as to the actual dry needling technique, but there was a confirmed radial nerve neuropraxia, a radial nerve injury that resulted in wrist drop following dry needling. Now, again, for lack of, and this occurred in Ireland, you can go find it out there. It's a free, I think it's a 2-page case report. Again, it goes through the patient's onset of symptoms. They reported to their physician, the urgent care department, and then it was managed there. But not much detail on the actual dry needling. For lack of having detail of the technique, I would tend to think that was a very aggressive, like pistoning, a very aggressive technique that would cause nerve, like mechanical structural nerve damage, a neuropraxia. There are also reports of plantar nerve sensitization, neuritis. And I should say this is not all unique to dry needling. There are similar reports. There's similar data for acupuncture. Honestly, probably the most nerve injuries occur with injections. First of all, they're sometimes injecting more sensitive structures. Secondly, it's a much larger needle, has much higher potential for destruction. So that's the ugly. If we are not cautious with our dosage, our application, and our needle, we can injure a nerve. Now, I start with that because almost everything I'm going to say after this is that we can very easily mitigate that. And that is a very rare occurrence. And honestly, the symptoms typically resolve very quickly. But the good, the bad, and the ugly, we're starting with the ugly. We can injure nerves with a needle, with any intramuscular technique. The ugly, if we go to the bad, if we know that we can do harm, and even if I start talking about how rare that is and how cavalier and aggressive you'd have to be to cause structural damage to a nerve, if we just take a step back, even a less intense interaction with a nerve is likely going to be an uncomfortable experience for our patients. And honestly, those brand new needlers with the terror in their eyes are not necessarily afraid of destroying a nerve, but they're afraid of causing any type of uncomfortable or, let's say, painful event for their patient. And if we're not intending to interact with a peripheral nerve, that might be the case. We'll talk about kind of the patient cues and the verbiage we'll use. But typically, if we're not intending to interact with a nerve, our words are achy, crampy, sore, a twitch, nothing specific to the response, the patient experience, and the words they'd use for a nerve interaction. So the lightning, the sharp, shocky, the ectopic sensory response from a nerve. So that's the bad. We know we can do harm. We likely know it will not be very comfortable for our patient. And I guess you could say what's bad is some of these nerves are impossible to avoid. When we talk about the specific anatomy, and thank you to the Barbell Physio and Matt Nadison for jumping on Instagram and saying that I have actually interacted with their peroneal nerves. It's true. The best of us, it's occurred. I'd actually personally say that the peroneal nerve is the most accessible nerve with our dry needling techniques. Either it's treating the short head of biceps femoris, where we know that common peroneal trunk is going towards the fibular head, or it's the superficial peroneal nerve as it traverses down the fibula. It's an impossible nerve to map. It takes a very anomalous course. And beyond that, we know everyone's anatomy is different. Their anatomy is anomalous. So I just say all that, like, we can do everything right. And the odds are, if you are needling for years throughout your career, it is more likely than not you're going to interact with the nerve. So I guess we'll say that's a bad. To some degree, it's impossible to avoid. But with that being said, we will talk about how to mitigate it, how to decrease the intensity of that experience for our patients. So we did the bad, the ugly. The good news, a nerve injury or even a severe nerve interaction that causes prolonged symptoms, lingering symptoms, is very rare. Risk assessment varies, but we're talking 0.01% or less. Of all of the things that can occur with a needle, pneumothorax, luckily, is one of the lowest. Nerve injury is right there with it in the same risk category. So this is very rare. The other good news is that, first of all, our anatomy protects our nerves pretty well. Nerves are typically very deep. They're protected by muscle and fascia, and just anatomically, they are protected. If there is any sort of interaction, and again, there's a big spectrum of a mild, a slight interaction, to a moderate, to a more intense interaction. But if it is a healthy nerve and a mild or moderate interaction with a peripheral nerve, typically the symptoms resolve very quickly. A slight interaction with a very healthy patient, by the time they're off the table, many times that quick discharge of a sensory experience from a nerve is gone. So the good news, the risk is very rare. Likely we can't damage a nerve. We'll talk about that in a second, but if we're comparing our tiny little monofilament needle to a hypodermic needle, even the potential destruction, even with a very aggressive dose or a very cavalier application of our monofilament needle, the chances that we can actually penetrate, disrupt that thick protective epineurium is very low. Again, there's very specific bony landmarks, the fibular head, maybe if you're going towards the issue of tuberosity. If a nerve is pinned against a bony landmark, maybe that increases the potential. But really, this tiny little monofilament needle and how thick and dense the epineurium of a peripheral nerve is, the potential that we are going to penetrate the nerve is very low. You can sensitize, you can get a discharge, an ectopic discharge, a very caustic response from a nerve without disrupting the epineurium, but the chance that we're doing mechanical injury and disruption to that nerve is very low. So going through, I guess we did the ugly, bad, good, good, bad, ugly in reverse order. Let's answer some of the more common questions that people have on courses or just, it just happened, what do I do now? So first of all, what will the patient feel? And I'll challenge you, if you know me, I'm an anatomy guy in general. I think it's as far as safety and precision and efficacy of dry needling, like there has to be a strong anatomical foundation, and that's not just muscular or myofascial. So the challenge here is know your nerves, and what will the patient feel really depends on the nerve. Very specifically, some nerves have a very high percentage of sensory innervation, afferent, and others are more motor. Some are purely motor. So what the patient experience will really depend on the nerve. And probably the best example of this is the gastroc. So the sural nerve is purely sensory. It's superficial. It splits the medial lateral gastroc heads. If you interacted with it, it would be a very sparkly, electric, nerve-like sensory experience to the calcaneus and Achilles. Comparing that to a more purely motor nerve, like the suprascapular nerve or even the tibial nerve is more motor than the sural nerve. That still will give you a sensory experience. And part of the anatomical challenge here is you should know your peripheral nerve patterns, because obviously that is how you know there was a nerve interaction. That just shot to the bottom of my foot. That just shot to my little toe. That just shot to my calcaneus. Those are three different peripheral nerves. And just with the localization of where the patient is saying they feel it, you know which nerve you're interacting with. So what will the patient feel? It might be very sensory, sharp, tingly, sparkly, spicy, like use whatever words you want to use, but we know the nerve-like words. If it is a less sensory nerve, or let's say it's not a mechanical contact with the nerve, but we are close enough to the nerve, typically the words you'll start hearing are a very deep ache. And deep ache is common description that we're used to hearing with dry needling, but this is a unique, it's a very visceral, deep, achy soreness that typically means a neurovascular structure. What else might they feel? If the patient has any sort of needle aversion at all, a interaction directly or almost an indirect, if you're close enough to a nerve, you can start to expect all of those sympathetic responses: sweating, goosebumps, getting a little pale, the GI churning, like all of those sympathetic responses. And I'm not even saying the vasovagal response of potential fainting, but all of that laundry list of the autonomic and sympathetic responses is going to be more likely if you are interacting with the nerve. So that's what the patient will feel. How long will it last? Let's say they just had that sharp sensory experience that just sparkled up my little toe. To me, I just am close enough that I just interacted with the superficial peroneal nerve. How long will it last? This is the most difficult question to answer, and it's going to be unsatisfying, but I will tell you there is a spectrum. If it is a healthy patient, a healthy nerve, and there really was a very quick or subtle interaction, that will resolve almost immediately. Honestly, oftentimes I leave that needle in and just continue to stim. And even with the stim, if I know that I'm getting some sort of electrical stimulation directly on the nerve, if it's tolerable for the patient, that is a good treatment to me. So to some degree, there's this end of the spectrum where there's almost very little concern for being close enough to a nerve. Again, you have to know the patient, you have to know the nerve. We have to, to some degree appreciate patient comfort. Then there's the other end of the spectrum, a less healthy patient. Say this is a chronic history of sciatic or tibial compromise. That nerve already is living in a less healthy nutritional environmental homeostasis, or maybe it's already mechanically sensitized, and then we add more mechanical trauma to it. That sort of discharge is when you might see lingering symptoms, prolonged symptoms. You might start to hear words like neuritis. So there's this large spectrum, and it has mainly to do with the type of nerve, the health of the patient, but also the the intensity of the interaction. And I'll talk about that when we talk about technique. So that's how long it will last. I know it's not satisfying, but it's just the truth. To some degree, if you know you're working with a very central nerve, like a sensitized patient or less healthy in the lifestyle, nutrition, the sleep, maybe our risk profile just went up and we are much more cautious as far as approaching a sensitive neurovascular structure. So let's talk about how to avoid this. And what I'm going to say first is you need to know your anatomy. You need to know where these nerves typically live. Even though there is anomalies, you can't take Netter's textbook and lay it on our patient and say, this is exactly where the nerve runs. But we have bony landmarks. We know the muscles that the nerve typically innervates, which follow its path. So we should have some general idea. We should follow the large bony landmarks, the ischial tuberosity for the sciatic, the popliteal fossa or the fibular head for the tibial and common peroneal. So have some idea of the anatomy and where they live. Otherwise, how to avoid a direct, uncomfortable interaction, or even, I'll say it a different way, you can get away with a lot as far as approaching sensitive structures. Right now, we're talking peripheral nerves. You can get away with a lot with a slow, measured advancement or a slow, measured approach towards the nerve versus the opposite, which is a very quick contact or even pistoning at or near a nerve. So when we teach level ones, whether it's a nerve or just really assessing the patient's response or even the tissue quality, the first insertion, the first depth assessment, when you're taking that first pass of a needle, whether you're looking for a bony backdrop or not, should be a slow, controlled kind of a mapping stroke, a depth assessment. And one reason we do that is if you're going to approach a nerve, if you do it very slowly, cautiously, even if you kind of get into that outer epineural covering, it would just be kind of this ghost, this trickling pseudoparesthesia versus a sharp lancinating sensory experience. So how do you avoid this? You know your anatomy, and then you approach cautiously. If you know you're on a muscle where the nerve either goes directly underneath or splits it or is directly adjacent, I would also add that maybe you'd minimize the amount of pistoning. I do think it's possible, even without a direct nerve contact, if we are aggressively giving this mechanical stimulus, pistoning a needle in and out right next door, it's possible to sensitize a nerve. And the last advice I'll give you as far as how to avoid, or really how to know if it's a nerve or if it's not a nerve, is to use stim. And really, this has been a revelation to me throughout my dry needling career. When I first started needling, we really didn't stim much. And when we did, it was kind of patient comfort, patient preference. Now I personally stim almost any needle I put in the body. And I have different reasons why I do it. It's blood flow, it's to decrease post-treatment soreness. One advantage I think e-stim gives to maybe a newer needler is you can confirm when you stim that needle exactly what structure you're interacting with. We know the localized response of a certain muscle, and then we also know the motor pattern of a nerve. And I bring that up because I treat shorthead of biceps femoris often, consistently. And the number of times I get my needle in, my bony contact, often I even get a twitch. None of the words the patient gives me make me think that my needle is near a nerve. But when I add e-stim on shorthead of biceps femoris, and you get activation of the anterior compartment, that just verifies to me, confirms to me that our needle, our anatomy, our muscular target is close enough to that nerve that when we introduce e-stim, you're stimulating the nerve. And again, for me, I'm trained in advanced nerve techniques, but whether that was my intent or not, to me, if I get that response, the muscles contracting, I'm getting a nerve motor response, I go back to, if it's comfortable for the patient, I keep it there. To some degree, I'm at the point where everything we do with the needle is input to our patient's nervous system. And if you want to talk about profound, novel inputs to the cortex or the central nervous system or the autonomic nervous system, having a nerve interaction is a positive in that sense with e-stim, just to be very clear. So how to avoid it? Know your anatomy, approach cautiously, maybe minimize pistoning, and maybe use e-stim. Patient cues. What if everything I just told you makes you think that I should be a little more cautious with short head of biceps femoris or peroneus longus or even lateral head of gastroc? What should I tell my patient? First of all, what I would not say to your patient, especially a very anxious, nervous, sensitized patient, what I would not say is, oh boy, there is a nerve here that I really don't want to hit the nerve. So if it feels like lancinating, lightening out your foot, just tell me, because that means, we might have interacted with it. That's what I would not say. My little pre-needle, my little 5-second spiel after you've done the consent, you've explained the procedure, is I say, achy, crampy, sore is normal. A twitch is actually a great response, even though you might not say it's perfectly comfortable. If it ever feels different or if it's ever too intense, let me know. And that's it. I don't put words in their mouth because we know the body language and we know the words of a nerve. So when you're going in, whatever muscle it is, and you get that big, wide eyeballed response of, whoo, that felt different. You just say, you stop advancing the needle, you stop pistoning and say, what are you feeling? They give you feels like a sparkle up my little toe. Excellent. And maybe that we stop advancing the needle, we stop pistoning, or we redirect. So you can get away with a lot with your approach, your technique, but also with your words. You can talk your patients into or out of a lot of sensitized responses. And that really goes into the experience, the confidence of a technique and anything in the clinic. This is just the patient rapport, the therapeutic alliance, if you will, just developing that rapport, allowing them to give you honest feedback, giving them your educated, their approach and what you should feel. And if it's different, let me know. So patient cues are big. Last common question, what should you do? You just contacted a nerve. Maybe they're not that healthy individual. Now you're like, oh boy, Whether you want to admit to them that you interacted with a nerve or not, that's really your professional decision. But what do? Can you mitigate or decrease those symptoms? Let's say that they are on the spectrum where you're like, I really don't want to sensitize this nerve that I think has already been traumatized, sensitized, etc. What should you do? First of all, there are probably some techniques we can use to decrease the symptoms. And I would put more emphasis on other manual therapy techniques. So give them a joint-based input with mobilization. Do some soft tissue techniques. Give them some cutaneous input. To some degree, we know that with Hilton's law, the innervation of the skin, the cutaneous layers that overlays the muscle, that overlies the joint, Hilton's law says that's all redundant. So we can, to some degree, override that afferent, that noxious input that we just gave to the nervous structure by giving muscular afferent input, joint-based, even cutaneous. So to some degree, give them that brief distraction. And even you can get into the hemodynamics of let's get blood pumping around that nerve. Like you can do that manually. You can do that with a more superficial e-stim. And we'll talk about that more in a second. Aside from manual therapy techniques, I would use movement. So first of all, find a pain-free movement pattern. And you're like, okay, when you do this, do you feel any of that, whatever, that sparkle, that tightness, that deep tension? Nope, feels fine. It's like, okay, we're just going to sit here and do this 50 times. Right now, it's not about strengthening or improving range of motion. Like we just want pain-free movement. Aside from that, load the joint, load the patient. It's fascinating what loading, what approximating and compressing joint surfaces, what getting that that neuromuscular, just reflexive activation of muscles can do to a highly sensitized patient or a sensitized nerve. So use load, and go back to the previous thought, use load in a pain-free, a comfortable pattern, in a tolerable resistance or in a tolerable volume. The one caution I would give is if we're painting this picture of a sensitized patient, we just sensitized the nerve, I would be cautious with mechanically sensitizing it further with sliders and gliders. I know the intent of a slider and glider is not to tension the nerve, but the potential is there. If we think of all of the potential osteofibrous and myofascial tethering, or even just a more chemosensitive nerve, and if you're going to try flossing that, unless this is your bread and butter, you know how to manage, you know how to cue, you know how to modify, I would be cautious with tensioning or gliders and sliders if you think you've just interacted with, potentially sensitized a peripheral nerve. So those are my recommendations. Again, as we start to wrap this up, to emphasize one thing, everything we've discussed in this little context, and I think I'm already past 15 minutes, I apologize. It's nice when I have guests on here because I can just cut off the conversation, but cutting off myself is much more challenging. Everything we've discussed today is peripheral nerve. The dorsal root is much different. Again, it does not have that anatomical, that very thick protective epineurium. It doesn't have it. It relies on the bony anatomy for its protection. Beyond that, it doesn't have a highly a vascular network or the hemodynamics that we can just pump blood directly into a dorsal root. It relies on its nutrition from the CSF and from the dura. So to some degree, everything I've said today, whether that makes you more or less cautious with a peripheral nerve, we need to have more caution, more respect for exiting nerve roots, whether it's cervical or lumbar. And maybe that can be a topic of another discussion, because those interactions are also possible. And to some degree, the healthy versus unhealthy is still true as far as how long those symptoms will last. But we put a little much more emphasis, a little more importance on avoiding the dorsal root. So with that being said, as we start to wrap up, again, if that made you more or less cautious, I just think we don't need to be afraid of peripheral nerves. Again, you can get away with a lot the way you approach a potentially sensitive structure. So don't be afraid of it. And again, to go back to the ugly, like there are reports that if we are too cavalier, we're just mechanically pistoning, pecking near a nerve or on a nerve, we have the potential to injure it, to destruct it. Probably more common is we can sensitize a nerve that is less healthy. But that is very rare. The symptoms rarely last more than off the table or even an hour or so. And again, our tiny little needle, when applied appropriately, likely doesn't have the resilience or the mechanical strength to penetrate a peripheral nerve. There are schools of thought that if we approach a nerve slowly enough, that covering will almost kind of roll, it'll push itself out of the way. We're almost tunneling towards it versus having a sharp object that can penetrate it. Again, I think that has more to do with the speed, the pace of our needle approach and in our pistoning. So I think we need to have a respect. I would not be afraid of it. To go back to the beginning, if you haven't already, you are going to interact with a peripheral nerve. Peroneal is a common one. Tibial's probably less common, but it's very possible if you treat the deep posterior compartment. The plantar nerves, there's actually another case study out there where there was a plantar nerve neuritis. They were treating just, posterior midline from the medial malleolus. So knowing your anatomy, that is directly where the tibial nerve is swinging in to become the plantar nerves. So the potential is there. So be respectful of anatomy, know your anatomy. And I guess these are my three things to conclude on. Know your anatomy, know your patient, and that's patient's health, how the patient tolerates the needles, and how much you trust them to give, for them to give us consistent feedback as to what they're feeling with the needle in. And then lastly is you need to own the technique. And partially that's practicing the art behind the science of using a needle. That's kind of our words, but also how we use a needle, how we approach soft tissue targets. But we need to own the technique. This is just one. This is a pretty minor adverse event if we want to categorize it. It's a minor adverse event. It's not urgent, typically does not require medical management, but we need to own the technique. And with that, we need to appreciate there are risks. Maybe we'll talk about pneumothorax someday. That's obviously the most severe adverse event that we could cause with our needle. And hopefully everything in our anatomy, our technique, our approach, our application minimizes that risk. But we need to own the technique. If we're using a needle, we need to know what are the risks, how do you avoid those risks, and honestly, how do you manage a situation if our patient is giving us the indicators that we need to address. I'd say what is more detrimental to our profession is denying that there are risks with a needle. Saying, yeah, this pneumothorax is not possible. I mean, the truth is that it is. They have been caused. We can be very safe, but the truth is you can cause a pneumothorax. Same thing with a nerve. We can't have a direct hit on a nerve and just tell our patient, nope, I mean, that's normal. That's a muscle. We need to say like, yeah, there are nerves in here. I don't think there was a direct contact. Honestly, it's very difficult for our needle to actually enter or injure a nerve, but I know this is uncomfortable. Let's do a few things to manage it. It's not denying risks or denying that any type of adverse event, even if it's minor, occurred. Honestly, I notify patients of almost anything like, yeah, it looks like there's going to be a small bruise here. That's not uncommon. Or yeah, that little sparkle you're feeling is, it's a small branch of a nerve right next to this muscle. The good news is, it's very challenging to injure. You probably won't feel much as soon as we're done needling here. If it's too uncomfortable, we'll take it out. Like patient is always in charge. So I leave you with that. Know your anatomy, know your patient, and own the technique. And we are over 15 minutes, but I hope that was succinct enough. I'd also, final challenge here and kind of a plug for us is dive into research a little bit. Honestly, one of our first guests on To The Point was Dr. Drew Ball. He has fascinating research on the femoral nerve specific to treating iliacus. And that brings in the component of patient positioning, which we haven't discussed yet. But if you can position the patient and that decreases our risk, even another 0.1, 0.01%, there are ways that we can mitigate risk even further. So dive into research. There's plenty of research that looks at algorithms and prediction models for pronator teres and the median nerve. There's ultrasonography research as far as the consistency, reliability of where the tibial bundle runs down the lower leg. So dive into research. That's the final challenge. And the plug from me is that iDryNeedle offers a free dry needling full text research library. So if you haven't checked that out, find our education platform. It's free. You enter your email and that's it. We update it monthly, but it goes everything: safety, adverse events, and then we get into the actual, the basic science, the pain modulating mechanisms, and then we go into anatomical regions. So even if you do a journal club or just task yourself one publication a month, whether it's safety or whether it's efficacy, is educate yourself, equip yourself with some of that research. And that's it for today. So if you have any questions, throw them up in the comments. This is going to be on YouTube. The audio will be on iTunes, Spotify, all of that. Or you can follow the link to our education platform. Again, this is iDryNeedle to the point. We'll be back in 2021 with some amazing guests. Honestly, the response we got in 2020 was incredible. And I 100% give that credit to our guests, the caliber of guests that joined us. So we have big shoes to fill, our own big shoes to fill in 2021, but we intend to do so. So have a happy new year. Enjoy some rest and relaxation. Stay safe, and we'll see you in 2021.